Welcome to the I Can See Clearly Now Good Experiences and Great Health Outcomes Through Effective Culturally Safe Primary Healthcare webinar series, and the second webinar, which is the case study about working together to achieve great health outcomes. And now to begin, we recognise the traditional custodians of the lands and seas on which we live and work, and we pay our respects to elders past and present. As per the first webinar, today's presenters are Dr. Mary Belfrage, who's a medical advisor for RACGP NACHO Partnership Project and a general practitioner. Mary has been a medical practitioner for 30 years. She has worked as a GP in community health and in Aboriginal community settings in both desert Aboriginal communities, and from 2009 to 2017 as the medical director at the Victorian Aboriginal Health Service in Melbourne. Mary has been involved for many years in teaching medical students and GP registrars about working effectively with Aboriginal patients and communities. She has also been involved in numerous research projects and held policy and clinical advisory roles in wide-ranging areas, including primary care, population health, effectiveness and acceptability of models of healthcare, and safety and quality of healthcare. Mary was an author of a chapter in the latest edition of the National Guide to Preventative Health Assessment for Aboriginal and Torres Strait Islander people, and was the clinical lead on the RACGP NACHO project to review and develop new recommendations for the MBS item 715 annual health check for Aboriginal and Torres Strait Islander people. We are also lucky tonight to be joined by Ms. Jacinta McKenzie, who's an integrated team care supervisor, Indigenous Health Project Officer with Wellness Our Way at Country and Outback Health. Jacinta has 20 years of significant experience working across many communities, primarily working on the complementary projects to support collaborations in the Aboriginal primary healthcare and mainstream GP practices. She has been a project group member for the NACHO and RACGP reference group to support implementing the National Guide and support mainstream general practices to deliver culturally targeted and responsive healthcare for Aboriginal and Torres Strait Islander people. She is also a member of the 715 Aboriginal Health Assessment Project Working Group. As a leader, Jacinta has a vision to inspire her community to motivate change and support culturally safe practices, and is determined to build partnerships and support equality and good healthcare outcomes. Jacinta's vision is to embed cultural safety by strengthening the pathways from the patient-centred care perspective and explore the strength of integrating cultural mentorship to care planning and follow-up care in the community. And last but most surely not least is Miss Ada Parry. Ada is a cultural and education advisor with the RACGP Faculty of Aboriginal and Torres Strait Islander Health. Ada is a Brinkin woman, a grandmother of 12, and her languages are Marithiel and Aningi Kungur. Ada has a long-standing relationship with the RACGP, from being a cultural educator of both medical students and GP registrars from 1986 to 2000, and has been a community representative on the RACGP Aboriginal and Torres Strait Islander Health Faculty Council in 2015. In 2018, Ada took on the role of Cultural and Education Advisor with the RACGP Faculty of Aboriginal and Torres Strait Islander Health, and is heavily involved in all areas of operations, ranging from education, training, and policy and advocacy. And now, onto the good bits. Here's Mary Belfrage to start the webinar.
Thanks, Daniela, and welcome to everyone, and thank you to everyone for accommodating our change of date for this webinar. Of course, COVID has demanded a lot of attention from all of us, and actually some of us have been involved in development of recommendations for the Aboriginal and Torres Strait Islander primary care where there are gaps in guidelines. And just as a by the way, this collaboration with NACHO, the National Peak Body of Aboriginal Health Services, the Lowitja Institute and the Australian National University has developed these recommendations, which went live yesterday the first of which went live yesterday and are available on the Natro website. Okay, so this is the second of 3 webinars about achieving great health outcomes in general practice for Aboriginal and Torres Strait Islander patients. In the first webinar, we talked about some of the principles underpinning culturally safe healthcare and explored the RSCGP Natro Resource Hub, which is housed on the college website. In this webinar, we're developing some of those same themes and hope to deepen your knowledge and understanding of what it takes to provide culturally safe healthcare and to recognise some of the barriers to healthcare that Aboriginal and Torres Strait Islander people commonly experience. We'll demonstrate the application of some of these key themes and offer some practical ways to work effectively with great outcomes through the case study that we're going to present. In the third and final webinar of the series, which is on next month, we'll be looking particularly at useful, high quality annual health checks for Aboriginal and Torres Strait Islander people and where these sit in the broader primary health care.
I try and help them, but they just don't listen. There's not enough money in Aboriginal health. They want everything for free. They never rock up, and then we lose our money. Why are you here? I haven't got time for this. Actually, we don't want to see you. Of course this place is culturally safe. We've done cultural awareness training. There's other cultures in Australia. Why should I focus on Aboriginal health?
The voice represents some of the comments that can affect engagement. Many of you may have had similar situations with complex clients and can relate to this story. Jenny is a middle-aged Aboriginal woman with complex health and social needs. She spent all day trying to reach out to services, hoping that someone will give her some time just to listen. She needed help and she was at a breaking point. Jenny reached out to a variety of services and every service she contacted asked her to make an appointment or mentioned they couldn't help her. She felt rejected, so she went to a community mental health service asking for help, and the representative stated to Jenny they couldn't help her because she didn't have a goal. Jenny stated, "My goal is to survive." So they brushed her off and referred her to the local Aboriginal health service as she was getting nowhere. So she was referred to an Aboriginal worker in a mainstream community mental health service. And to Jenny, this was her last service of hope. Jenny presented at this service and stated, "I have nowhere else to go. I've been everywhere." The service recognised she was agitated, distressed, upset and anxious. She asked to speak to an Aboriginal worker about her story as she felt hopeless and stated that no one cares. Jenny was invited to speak to an Aboriginal worker who was part of the integrated team care known as ITC. This is where Jenny's journey started.
So this experience of going to lots of services and not getting good health care, not really engaging or not landing there is common. People describe feeling judged and rejected, of getting a clear message that they're not a good fit for the service. And sometimes this is about specific eligibility or ineligibility criteria. Sometimes it's about not feeling welcome or safe. Sometimes it's about not being offered services that match what the person is seeking. And sometimes it's frank racism, like this service isn't for you, there's an Aboriginal health service down the road.
Yes, I wanted to say that, sometimes for our people, it's uncomfortable walking into a place of unknown, but the story is out there for our people in amongst the Aboriginal community where community services are available or not, and it either way it makes it harder or easier for our mob to attend. It's it's about making people comfortable when they come to your services, and making them feel welcome when they come into your services.
Thanks, Ada. So it's important to understand the impacts of intergenerational trauma, as this is linked to many Aboriginal and Torres Strait Islander people's experiences. So be gentle and show some empathy. So in moving forward to the safe space, this was important for Jenny, as she needed to feel that she had privacy and a space to talk openly with dignity, where she wasn't going to be judged. The Aboriginal worker, just to let you know, had a stay safe icon in her mobile, just so that she was safe when she was talking to Jenny. She mentioned to Jenny she had some time to yarn, to talk to her and see if she was okay. Jenny stated she was feeling angry and expressed suicide ideations. The Aboriginal worker listened to Jenny as she was opening up. This was the most important step. And when she was calm, the worker was able to ask questions that wasn't intrusive. She just needed to work in a way that identified her health needs, including her eligibility for services, as this was Jenny's last place of hope. It was important that Jenny fit the criteria somehow, and if she didn't have a chronic disease, she wasn't eligible to access the ITC program. So we had to make sure that the criteria fit Jenny. This is where the next stage for culturally safe healthcare began for Jenny, and she continued to share her story.
Yeah, I think the striking thing is how Jenny responded to what was offered, the care that was taken, that there was an Aboriginal worker available. So that was the Integrated Team Care Aboriginal Outreach Worker, that people took the time to listen and tune in and weren't rushing to check whether or not she was eligible for services. So, Ada, do you want to say a bit more about why that makes a difference? And I think also, you know, what if there isn't an Aboriginal worker or staff member? What are the things that make a difference to an Aboriginal person feeling welcome and safe?
I think for me, it's taking the time to listen and showing empathy. It really makes a lot of difference for people who are new to your clinic. It makes the person feel worthwhile and valued when someone spends a bit of time with them.
How much of a difference does it make if, you know, for a lot of GPs, there's not always going to be an Aboriginal worker available?
Well, I think, you know, a lot of people who become doctors, in the beginning, they want to help people, and I don't think that helping people should go out the window when it comes to Aboriginal people or other people that aren't from your cultural background.
I've always found, even when there isn't an Aboriginal person who's part of the healthcare team, that if I'm listening carefully and respectful and kind, that people, you know, the consultation will usually go very well and people are likely to come back.
Yeah, it sure does, Mary. Especially when people are so empathetic, you know, with patients who probably don't know anything about medical stuff, you know. But just having someone talk to them in a gentle way makes a lot of difference.
Yeah, yeah. Okay, let's keep going with Jenny.
So finding a GP, as you can understand, a client may have their file at a few destinations, so the medical history and relevant medical information can be hard to gather, and this can be difficult when assessing clients. In this case, The Aboriginal worker asked Jenny which doctor she wanted to see. She couldn't remember the doctor, but she remembered the practice. The worker managed to get an urgent appointment with a GP that Jenny had contact with in the past. The worker also spoke to Jenny about another worker providing support, so there were 2 workers with her, which can be too much, but in this case was okay. The worker recognised that Jenny's healthcare needs and mental health was priority. The workers transported Jenny to her appointment, and she had no means of transport. You may hear the term walkabout, foot falcon, or no motorcar, meaning no car, using her sense of humour during hard times. And just to share a moment in the car, one of the workers had mentioned, "It's a nice day today," and Jenny replied, "Who cares about the day?" Then the worker knew this was a case of listening, and that was the key. The next steps into the practice was again important. The receptionist was welcoming and calm, acknowledged Jenny and guided her to a safe space waiting for the GP. The GP invited Jenny into her area, and she spoke with Jenny with respect, empathy, and focused on listening while Jenny expressed her worries without being cut off or judged. The GP assessed her mental health, and this was vital to stabilising Jenny. After this consult, the worker transported Jenny to the pharmacy to get her medication sorted. She was signed up for closing the gap for her prescriptions, as Jenny had no bunda, meaning money.
I
Thank
think
you, Mary.
the important things here are the Aboriginal outreach worker knew what was needed and knew how to navigate the service system, which not all patients will feel confident doing. So the Aboriginal outreach worker was able to get the urgent appointment. The practice was welcoming. And once Jenny was at the practice, or for a patient like Jenny, I think it's really important to be mindful about not reflecting the chaos and crisis of the patient, to take time and to identify clear priorities that are in tune with the patient needs, to not overwhelm the patient by trying to do too much, which is, I think, a real trap when you do establish rapport and you're wanting to do something useful for the patient. There's a temptation to do too much, and that sort of being opportunistic, which is part of our training and what we're on the lookout for, can, I think, be experienced as overwhelming for the patient. That sort of pouncing on people and trying to do healthcare to them, and can scare people off. And it's definitely one of the issues for junior doctors. We've had lots of GP registrars, but for junior doctors to encourage them to sort of temper their enthusiasm and not try and do too much, but to focus on establishing a relationship and trust, and just doing a little bit and making the next appointment. Ada, do you want to say a bit more about what helps people to feel safe and to engage with a GP?
I think as a starting point, for the GP to make small talk, getting to know the patient by, ice-breaking questions, and think about what that person has come in for today, not what you're thinking about, but why they've come in and what it feels like for your patient to come into your clinic today. Is it easy for an Aboriginal person to come in today? It may have been not so easy, but anyway, and also at the same time looking after you as the GP, and pacing yourself with that patient and acknowledging what the patient has come in for, the responsibilities you might have and the responsibilities you might have, all those sorts of things. We don't come in, Aboriginal people don't come in alone. We come with all our baggage, And some of you may have experienced that because maybe of conversations with your friends or your patients, but you have to keep that in mind.
No.
Thanks, Ada. So moving to Jenny and her healthcare team. Jenny's knowledge and understanding in accessing healthcare was limited. Therefore, planning her care was key to support her build her knowledge and network. So over a period of 6 months, Jenny had weekly appointments with her GP and also had regular contact with the practice nurse. It's important to highlight that for the weekly appointments to work for Jenny, they needed to be scheduled by Jenny. Her time, but fitting into the practice times of availability that was close to her request. So the same time each week was scheduled, and the practice nurse and Aboriginal worker made reminder calls a day before to keep Jenny engaged. This was important. As you can see in this section, health needs identified. Some of the complexities around Jenny's health and well-being is a lot for Jenny to be trying to manage, considering her mental health. It was important to help Jenny on the right track and look after her health better. She had significant health issues. She is a smoker of cigarettes and yarndi, meaning marijuana, and loves drinking, and I can guarantee it's not water, by the way. I would also like to feedback that Jenny's support system with the health system and Aboriginal workers supported her engagement in returning for health care. Information provided to Jenny was clear and her health needs were planned according to Jenny. Jenny taking control of her health her way. So moving forward into parts of the 715 Aboriginal Health Check, this assessment was in no order of the assessment for the 715 Health Check. It was broken up to different stages in a weekly consult at Jenny's pace. I'd like to share with you a question that was put to Jenny by the GP about her physical activity, as she was a bit overweight. Jenny stated, "I walk to the letterbox and that's it." The GP replied, "Maybe walk a bit more. Walk around the block." Jenny replied it was cold. The GP responded with, "Put a jumper on, just try and walk, that's all I'm asking, and it's good for our health." So maybe another suggestion is walk in warmer weather, because this fits Jenny. We all know how this feels when we think about it, and at times even we feel the weather impacts our choices. So Jenny, you're not alone. The remaining appointments were scheduled around the 715 Women's Health Check, dental, biomedical, and referrals to allied health. The appointments were purposeful, and a lot of planning and team care arrangements went into supporting a complex case. Thanks, Mary.
Well, do you want to say a bit more just into about the different aspects of her care?
So as you can see in the 4 boxes, her care was coordinated in this approach. So it wasn't always in order. Everything went according to Jenny and when Jenny was available. As you can see in the first box, we had ITC, registered nurse for care coordination, who provided support and access to navigate all the other areas. So from the 715 health assessment, the referral pathways into the other areas was quite important. So Jenny needed a lot of advocacy in regards to what that pathway looked like, because a piece of paper and a contact number wasn't good enough for Jenny. So we had to make sure that we used appropriate forms in regards to accessing allied health and looking at how we can report back in regards to summarising all the steps and the pathways that Jenny had accessed in order to keep up to date with her case. So as you can see, allied health access, after the 715 Aboriginal Health Check, there are free access to those areas. And Jenny had made sure she had access. Her most important access was the optometrist out of that list. But it's important to also note that, looking after her mental health, that we had to make sure that it was cultural appropriate in different stages. So the narrative therapy and social emotional wellbeing groups also provided Jenny with some strength. And so that's what helped Jenny stay strong within this case. Thanks, Mary.
Cool. Thanks, Jane. So I think the key feature here is that the approach to Jenny's healthcare is built on working together, not just the doctor doing and telling, but working in partnership and supporting Jenny's agency. And this is a foundational principle of trauma-informed care. Recognising trauma as a bedrock issue for people like Jenny is important. This cascade effect on physical health and social and emotional well-being and mental health that presents in exactly this way with complex medical and social needs. And at the end of the presentation, which you'll have access to, there are some resources that are around trauma-informed care. But this, you know, in my experience, Jenny's mix of the medical complexity and the social complexity is common. So given this complexity, actually, despite this complexity, the complexity of Jenny's healthcare needs, the approach is planned and well organised, and each step is negotiated and happens at a pace that works for Jenny. And there's a real challenge in all this complexity to not be overwhelmed as a clinician. It's so easy to be busy but not effective. And I think this is one of our high-level clinical skills as GP, and you know, one that I always felt was a key learning for GP registrars who did placements with us. That challenge of being organised within a consultation with someone who presents with often in crisis and with lots of complexity, and then to, as well as the individual consultations, then to have a meaningful plan that actually supports good health outcomes for people over time. Having an Aboriginal worker is gold. It builds trust and confidence for the patient in what is being offered, and allows understanding and communication to be checked in both directions, in two ways, for the clinicians and for the patient. And it really paves the way for a GP, for the GP to offer services in a way that is useful and effective. Ada, do you want to say a bit about having an Aboriginal health worker or an Aboriginal staff member in the healthcare team and in the consultation?
Yeah, thanks, Mary. If you do have an Aboriginal person working in your clinic, make sure that that you make use of that person, because that person is not only there for the doctor and the clinic staff, she's there to pave the way, or he pave the way for the patient, working and understanding and learning. And even if you don't, I mean, you know, if you're a doctor and you're the one that's made this choice to work with, you know, people from the public, you can do it on your own as well. You know your business, and that Aboriginal person, if you've got one, knows their business. So you can, together you can make it work.
Yeah. Thanks, Ada.
Thanks, Ada. So Jenny and her healthcare team. I just wanted to touch base on Jenny, how Jenny and the Aboriginal worker went for an eye assessment. Jenny wanted bling. What's a pair of glasses without bling? Well, in this case, the bling had to be at her cost, and the worker stated, You need the lens more than the bling. Jenny laughed. Jenny stated she couldn't afford glasses, so access to ITC supplementary services provided support, as she was registered with ITC. And if this access didn't work, she was going to explore the native title group with support with some medical aids. The next appointment, the GP had to give to Jenny her depot, noticing improvements. So she asked Jenny how her lifestyle is. Jenny described the complexities around this, which I'm sure the GP was thinking where to start. But in Jenny's day-to-day life, it's normal. Overcrowding and family problems. So the GP let her speak openly, and Jenny asked the GP if she had a cleaner. This opened the conversation more, but funny enough, the GP had no comment and smiled. The GP had one last question in the consult, a section around activity. So you're probably wondering what type of activity they were referring to. This was a sensitive topic relating to sexual health conversations. Jenny looked up to the ceiling, looked at the doctor looked at the Aboriginal worker, the Jenny stated out aloud, "Nah, don't touch my man." So you know where this conversation went. The box was ticked, but it was followed up sensitively. And I just want to mention as well that the weekly appointments continued. Her mental health care plan was addressed, and a 715 Aboriginal health check was completed in stages of 6 months. The TCA, team care arrangements, was up for review, and the practice nurse followed up with a 2 weekly depot, psych injections, and coordination of care with ITC for pathology, allied health appointments, and recalls. The medication review was also part of this, and Jenny's care was followed through. Information was provided to Jenny by the pharmacy as she wasn't eligible for QMAX, quality use of medicines, and a home medication review was also followed up. So the pharmacy provided extra support with a Webster pack, and it's important that access to ITC across your area to follow the care is a good part of care coordination, and the outreach worker supports this and assists the journey and supports access to good healthcare. The ITC workers also have a project officer who can also support your practice with closing the gap initiatives, cultural endorsement programs, and to support welcoming environments, and also provide cultural awareness training to build knowledge and support cultural appropriate healthcare. This program comes under the PHN. I would also like to share with you that Jenny's glasses were ready in 2 weeks, and the worker had to drop the glasses off to Jenny outside her home. Jenny was smoking, so the worker remained inside. The glasses were provided to Jenny, and Jenny embraced the work and stated, "I can see clearly now, the rain has gone, I can see all obstacles in my way." She also stated, "I'll be going away for Christmas," and this was an important stage for Jenny, as we had to set up emergency support and organise the aftercare. Jenny was going away to homelands for healing and to be grounded on country. She saw a nunkri known as a traditional healer, and she spent time with family. Over to you, Mary.
Yeah, thanks, Jay. So, there's a whole lot that's working really well for Jenny, and we'll come back to her story, but just want to do a bit of housekeeping and to remind people how all these services are funded. There's a whole lot that are funded through the MBS, the general time-based consults, the extended primary care items such as care plans and reviews, the team care arrangements, case conferencing, etc., medication review. There's the Aboriginal and Torres Strait Islander specific items, like particularly the health checks, 715 or 228, or now in this COVID era, the telehealth based items, and the follow-up items that are facilitated by completion of a health check that can be done by practice nurses and Aboriginal health workers. There's all the allied health services, although that's limited MBS reimbursement and doesn't cover the cost of private allied health services. There's mental health services through the Better Access Initiative, and medications, which since I think it was 2010 have been funded through the PBS co-payment arrangement, commonly called the CTG or Close the Gap arrangement. There's also all the services that the integrated team care program provides, the ITC program, and every PHN is funded to administer the ITC, which, as well as the advocacy and support services, can provide transport and equipment and co-payments, as Jenny experienced. And then there are other local government services that may be available. The local Aboriginal Health Services may provide some services even to Aboriginal and Torres Strait Islander people who aren't attending those services. That varies regionally. So really need to check on the details of what services are available locally. I think I didn't mention also the Indigenous Health Incentive for accredited practices, which is most. There's the Indigenous Health PIP, and fairly substantial registration, and then tier 1 and 2 outcome payments to remunerate the provision of complex care, like the sort of care that people like Jenny need. Okay, so back to Jenny.
So Jenny today, she's had her 715 Aboriginal health check and mental health care plan completed. Intensive care coordination for a period of 6 months. Now she's in the low category for follow-up. Jenny is independently accessing healthcare for herself. She has a better understanding of healthcare, and she has better relationships with some family members, her immediate family members. There's improvement in her health literacy, so she's understanding each component of her healthcare needs. She has information relating to her health, and she has primary contacts. She has direct contact with the GP, so there's no more juggling different services. She has one main contact, and that's her GP looking after her care. Jenny previously wasn't engaged in healthcare at all, but as you can see now, she is. Jenny only calls the ITC worker, the Aboriginal worker, now for a taxi voucher, and this is to support her to get to her appointments. This is moving towards supporting her independence. The ITC worker no longer attends her appointments, as Jenny attends her on her own with her partner. She attends women's groups and tobacco awareness groups for support and education. And Jenny has more contact with family and looks after her nieces and nephews. She has gained trust within her family and has better relationships. She has a regular depot and she has never missed any to date. Jenny's mental health is stable. She does have her up and down days and will seek help at the right service she can rely on for support. There is no guarantee that things are smooth, and this is a case where it's stabilised, and that's what matters. She has control of her life and manages the best way she can. That suits Jenny. She receives her Webster Pack for medication management, and the Aboriginal worker noticed Jenny has more motivation and seems at ease, and she's communicating really respectfully. The ITC program provides chronic disease management support according to a GPMP, aiming towards self-management. The support for travel to specialist appointments to the city has a clear travel plan, and ITC supports travel and access to PATS. Jenny is self-managing and she is not demanding services. She is spending a lot of time with her elders and is socialising with the women's group as her support network. She's yarning up about cancer and other preventative health issues, and she's supported by women in that group. Jenny will be discharged from the ITC program soon, and the Aboriginal worker had permission to do her evaluation and asked her, "Are you happy?" And this was completed and she was happy with all the services. Over to you, Mary.
Well, I think it's just up to you to share the most positive moment.
So Jenny's most positive moment was when the Aboriginal worker gave Jenny her glasses in a case. Jenny opened it up and smiled. She tried the glasses on, and the words that came out of her mouth were, "I can see clearly now, the rain has gone." Jenny gave the Aboriginal worker a hug and said thank you. And then she continued to walk back to her house singing, "I can see all obstacles in my way."
We so
Thanks,
wanted
Anne.
to play the soundtrack for you, but we couldn't get copyright. So, yeah, thanks, Jay. You know, this is just such a good story of great outcomes. And, you know, this is a patient who started the journey with a lot of complex needs and no confidence that anyone would or possibly could help her. And she was supported firstly to engage and slowly to take control of her health and healthcare. She had strong support from the Aboriginal outreach worker, which was really important in practical ways, getting her into the practice, and especially initially in building cultural safety and trust. But that way of working wasn't about building dependency. It was really about building her agency. And then there was a whole of practice commitment to continuity of her care, to being responsive and kind and flexible. So rather than finding her too hard, that sort of heart sink feeling that we can feel with very complex patients that can feel hopeless, this was actually a rewarding experience for the practice team, as well as being so obviously good for Jenny. Do you want to add to that, Ada?
Yeah, I just wanted to say a true partnership for you as a GP is with your staff and your patients, and being able to depend on one another to do a good job, from the receptionist to the Aboriginal worker to the GP. Everyone knowing what is expected when the patient comes to the clinic.
Yeah. Okay, so as we finish up, we just want to share a couple of slides that outline some of the high-level relevant principles to working effectively in healthcare with Aboriginal and Torres Strait Islander peoples. And these slides, we're not going to go through them in detail, but you'll have access to their presentation, and these will be available for your consideration. So this one, as it states, is about social and emotional well-being. And these principles, which were first described by Pat Swan and Beverly Raphael in 1995 in a fairly sort of landmark report, have been continue to be used and to inform, you know, they're the guiding principles for the National Strategic Framework for Aboriginal and Torres Strait Islander people's mental health and social and emotional wellbeing, 2017 to 2023, and we've got a link to that in the resources page. And then the other slide is well, this slide is a sort of distillation of my reflections over many years in clinical practice and as a teacher and mentor, and in program and policy advisory roles, about sort of key domains or elements that are important in terms of working effectively in Aboriginal health. And we could, you know, happily talk in detail about all or any of these. But, you know, for those of you who like a framework and who think in principles, I thought this might be a sort of useful bird's eye view. In the resources, there are some links to different aspects of these. Yeah. So, firstly, for the resources, these are the college resources. The first one, the Resource Hub, has got a whole range of resources, and we'll be looking at some of those we did in the first webinar, and we'll revisit that in the third webinar, which will have the focus on health checks, but also the National Guide to Preventive Health Assessment for Aboriginal and Torres Strait Islander people. There's a link there, and some of the other resources that the college has. Then some other resources around trauma-informed care and identification and cultural safety. So just bring those to your attention. And finally, if we've got any questions, we're happy to take questions.
Thank you, Mary and presenters. We do have a couple of questions I think would be lovely to get to. We have a couple more minutes, so if anybody has any other questions, please type them in the question box and we will get to them post-webinar. But panelists, if we could start with a question, we have, my experience is that an Aboriginal patient comes to see GP. It's easy to manage the acute conditions or acute on chronic conditions, but ongoing condition management and preventative care is very difficult. Do you have any comments and or any suggestions on what one can do in that space?
Yes, just Mary?
Right, will you go, Jay?
Yeah, I was just going to mention access your local PHN integrated team care for chronic disease support management and care coordination. They have access to outreach workers in the area.
Yeah, I think, I mean, I think wondering about the timing of that question, because I think that's partly what we've been talking about tonight. I think that the really essential component of being able to work effectively in the long term is about establishing an effective therapeutic relationship. So establishing trust and hopefully some of the what we've presented tonight, helps you to think about how you do that. But I think establishing trust and working at a pace that is in tune with the patient and acknowledging the context of that person's life and all the things that are going on for them, and the is really important. Understanding what the what I call those sort of bedrock issues. I think it's just so common that for many Aboriginal people that the impact of trauma is so huge, and that's the reverberation of invasion and colonisation, and the way that has cascades down through generations, and then the individual experience of the patient that in consultation with you, what their personal experience is as well. And I think understanding for people with very complex medical and social needs, having an understanding of trauma is really key. And I encourage people to look at the Healing Foundation and the Blue Notch trauma-informed guidelines.
Great. Thank you, Mary. We've got one that I'm wondering whether, because on the line that you're on at the moment, whether it would be easy for you guys to provide some maybe almost like handy hints, because we've got a question here that mentions that making complex coordinated team care plans for patients, that sometimes the GP can maybe feel overwhelmed or overwhelm the actual patients. Would you have any suggestions or handy hints on how to avoid the patient becoming overwhelmed with the complexity of the planning?
Yeah, I think it's a really key question. It really tests our clinical skills in a particular way. I think, as I described, it's so easy to be busy but not effective. It's so easy to reflect the crisis and anguish and chaos that people can present with. And I'm definitely, you know, when I was the clinical director at the Victorian Aboriginal Health Service, it was one of the things I talked with staff a lot about, is how we could hold, in that psychological sense, hold the chaos and suffering, anguish that people came with, but not be reflecting back the chaos. So I think the impulse to try and do a lot, it needs, you know, it's really good to notice that, and to be thoughtful, you know, gentle and calm, and not anxious about trying to get too much done. And, you know, there are things that really push us to do that. There's medico-legal issues can really put pressure on to try and do too much. But I would just strongly have a strong sense that if the engagement is real, and you can work in a gentle way with people, then medico-legal issues don't arise, and it's, you know, that anxiety to try and attend to things that meet guidelines can just be put to the side, and to navigate and negotiate priorities and just go, you know, work through methodically is a much more effective way of working, and really does produce good outcomes. As we've seen tonight, this is a real life case. You know, this is Jenny's a real person. Yeah.
Wonderful. We've got a couple of minutes left, and I want to sneak in another great question that we received. Is there any way that the Aboriginal patient can be managed well without having an Aboriginal health worker in the practice?
Yes, is the answer. I think that there's huge advantages in working as a non-Indigenous clinician, in working alongside Aboriginal workers, health workers, or support workers, or, you know, it's huge. But it's entirely possible to work effectively without Aboriginal people in the consultation, without Aboriginal staff in the consultation too. And I think that the general things of being respectful and kind, and having high standards of clinical practice, and checking with the patient, work really well. There's a couple of things I just want to add, because it's also really important in this conversation that we acknowledge the shortcomings of generalising. There's lots of Aboriginal, you know, the case that we've presented tonight is typical in some ways, but it's not all Aboriginal people, and, you know, stereotyping doesn't work. There's also another principle that's really important, which is about choice, that Aboriginal people, some will choose to go to Aboriginal organisations, health services, and others choose very deliberately not to. So I think that that's also a really important principle.
Fantastic. And just on that line about choice, in mainstream, they may not have Aboriginal health workers. Is there a way to engage one for a patient if they want one, or if the practice feels that they should have one?
Yeah, well, through the PHN, the ITC workers have, I don't absolutely know for sure that every ITC team has Aboriginal workers, but that's certainly the intention. So that's one way to have Aboriginal workers in the healthcare team. But also the scope of practice of Aboriginal health workers has been expanded, and Aboriginal health workers work in some community health centres, and I think can be employed in private general practices, and hopefully increasingly we'll see that, particularly in practices where there are large numbers of Aboriginal patients.
Great. Now we have reached our time. Thank you very much to everybody else that has submitted your question. Sorry that we didn't get time to get to those questions to answer them, but we will definitely do a fact sheet for everybody and send that out through to anybody. And just before we close off, Jacinta would like to say just a word or two.
Thank you everybody for joining us today. We look forward to seeing you at our third and final webinar in the series where we'll be focusing on health checks. Webinar 3, quality health checks and ongoing primary health care. Thank you.
And
Thanks,
thank you everyone for joining us. Thank you presenters, and all have a lovely night. Thank you very much.
Thank you.
Thanks, Daniela.